Hello, this video is for radiologic technology students to learn the radiographic criteria of a chest x-ray and how to assess a chest x-ray for diagnostic quality. So the first thing that we want to do for chest x-ray is to identify that we have not clipped any of the lung field and the pertinent anatomy that is in the lung field. So what we do is we start at the top and make sure that we can see the apices of the lungs, which is the most superior part of our lungs, the apices. So we'll make sure that I go to see the ribs here, the first rib. I look for that first rib, and then I know that I have not clipped any part of the apices of the lungs superiorly. Then I go all the way down to the bottom and make sure that inferiorly we have included the costophrenic angles down here. The costophrenic angles of the lungs, the right and left costophrenic angles of the lungs are included in this chest x-ray. So I know that I have not clipped any anatomy superiorly or inferiorly. Then I will go to the lateral borders of the ribs here to make sure that I can see both right and left lateral borders of the ribs, and I can. So I know that I have not clipped either the right or left lung from this image. Now that I know that I've got the entire lungs included in the image and what has to be shown, let's look at the different pieces of anatomy and the structures and how they're supposed to be identified on the image to know that this is a diagnostic image that can be sent to be read by a radiologist. So we looked for the costophrenic angles down low. So we can kind of follow those costophrenic angles around the diaphragm, right? So we need to make sure that we see the both right and left hemidiaphragm down here. And then let's go back up top and look for the trachea. The trachea will be centered down the spine here. That gray area in here is the trachea. And we can follow the trachea down to about level T5, T6, thoracic vertebra levels T5, T6 to find that bifurcation of the trachea here called the carina. That's where the trachea branches off into the right and left bronchi. So we look for that little area right in here called the carina. All right, then we will look to see that we have the aortic arch here. We can identify the aortic arch. We'll be looking to see the entire heart shadow in the image. We'll want to be able to see the spine through the heart shadow. We won't be looking so much for spiny structures on the vertebra, like not the vertebral structures, but we'll look to see the shadow of the spine through the shadow of the heart. That way we know that we used enough kV to penetrate all the way through the patient. Also, another thing that helps us to identify our technique, that we set the right technique, is by looking for the little lung markings. The lung markings are the vessels and the lung tissues. So all of these little white squiggly lines we see, that's all part of the lung tissue and vessels that are in the lungs. So we call those lung markings, and we make sure that we can see those lung markings. That's why we consider a chest x-ray a long scale contrast image, because we see all of these very tiny grays and all these little shades of gray in there. If we don't see these little lung markings and it's very black in this area, it could mean that the patient either has a pneumothorax or that we may have used too much mass and burned out the visualization of those lung markings there. So it has a lot to do with the technique that we set for our chest x-rays. In this area here, where it's a little bit more opaque, right here, laterally on the lateral borders of the heart here, we call this the hilar region or the hilum. This is where the great vessels enter and exit the heart. So we also look to see the hilar region, laterally from the heart there. And then another thing that's very, very important with our chest x-rays is that we want to try, if the patient can, if they're standing up for a PA chest x-ray, if they're sitting up in a stretcher, or if they're in their hospital bed, if they can roll their shoulders forward, we would ask them to do that because what we don't want is what we're seeing here in this x-ray. If you can see this little shadow here, this is the scapula that we're seeing. So we're seeing the vertebral border of the scapula here, and all of this little grayish area in here is scapula superimposing the lung fields. And that we do not want to see in our x-ray. So what we'll do is ask our patient to roll their shoulders forward if they can, and then that will bring the scapula out laterally away from the lung field as much as we can get it out of the lung field. So that's one thing I would say that you would want to see better on this image maybe. But I wasn't there. We don't know the patient's condition, right? All right, and then another thing that's very important is making sure that we get a nice deep inspiration. We want to have the patient take a nice big deep inspiration in so that they fill those lungs up and they expand the lungs as much as they possibly can. So in order to identify that the patient took a nice big deep breath in and was able to expand their lungs for us for the image, we count the ribs. We count the posterior ribs. So I'm going to show you how to identify the posterior ribs from the anterior ribs, and then we're going to count the ribs off. So the very first rib is a short rib. It's right here. It's a little, it looks like a little, I call it the curly Q, but it's just a very short rib here, okay? And it kind of helps us to identify the area of the apices, that most superior part of the lung. So that would be rib 1. Rib 2 crosses over rib 1 here. Rib 2, I'm following it all the way to the anterior part. So the part of the rib that attaches to the vertebral, the spine, is the posterior rib. The posterior ribs are more horizontal. And then as we get to the angle of the rib here, where it curves around anteriorly, you'll see that the rib starts to point inferiorly, almost like an arrow pointing downward, right? And that is the anterior rib. So we count the posterior ribs because those anterior ribs kind of start to get lost along the way, you know, on some patients' x-rays. It's just easier to find those posterior ribs. So we say rib 1, then we'll come back here, find where rib 2 attaches to the spine. That's rib 2, rib 3, rib 4, 5, 6, 7, 8, 9, 10. Then a little bit of 11 here, but we need to see at least 9 to 10 posterior ribs above the diaphragm. So let's go over to the left side of the patient's body. Let's check this out. First rib, then we can find the second rib here, third, fourth rib here, fifth, sixth, 7, 8, 9, 10, 11 posterior ribs seen above the diaphragm on the left side. So we can tell by that, you know, by counting out those ribs, that they got a nice big inhalation and we're able to expand the lungs for us. So that is how we can identify that we have all of the anatomy included on the image that we need, and then it's a diagnostic image for the radiologist to read. I hope this was helpful. Thank you for watching.